Now, as a team leader, as soon as the patient arrives, you would first check, confirm whether it's cardiac arrest. Now, if compressions are going on, you could let the compressions go on, and if they've just been started. But otherwise, first thing, confirm cardiac arrest. How would you do that? Check if there's any response in the patient. Check uh, pulse and breathing, and get the patient connected to the monitor, so that you can know um, uh, what's the rhythm and other bits, and the other vitals, if they are recordable. So you confirm cardiac arrest, so no response, no pulse, breathing, and nothing on the monitor, and you call out. So team, this is, so you confirm that it is cardiac arrest, you call it out, and then command your team and commence. So what would you commence? The life support again. So once you have confirmed it cardiac arrest, get confirm call it out to your team and commence your life support. So what would you do? Think think this flow, is it ongoing, and what more you can do. So think compression, so immediately tell this person to, he's check pulse, so you would tell him to do chest compressions, and ensure good quality chest compressions are going on. You ask now once that is going on, you ask the person to attach pads at the defibrillator end, and he is connecting all the monitor bits, other bits, and getting defibrillator on. You as the chest compression is going on, you ask the person at the airway to um, you hand over the responsibility to this person regarding the airway, but um, ensure now if no definitive airway is there, so after every 30 compressions, two um, breaths are given, such that there is adequate chest rise. So you are ensuring that good quality CPR is going on. You also ensure that patient the oxygen is connected, and then think, you've already talked about airway, you would think and good chest rise, and ask them to consider if they have any plan to put an advanced airway, and at what time they would be able to do that. So this 2 minutes are going on. So quality, or you've ensured that if it is cardiac arrest, you are continuing good quality CPR is going on. Now at as the 2 minutes get over, you, what would you do? You would ask this person who was doing the chest compressions, or maybe whosoever has better access to the neck at that point, to check pulse. And what would you do? So you are basically checking response of whatever you have done in the last 2 minutes. So remember, checking for ROSC, 3 R's: ROSC, rhythm, and think roll switch. So is there any pulse? So no pulse, and the person says, okay, rhythm, it appears shockable or non-shockable. So let's say if he says non-shockable rhythm, and then you look at if the person, at every 2 minutes, you should consider somebody to switch the roles of the person who's doing chest compression, because they could be getting tired. So in within 10 seconds do that. And then your next thing is, um, if it is a non-shockable rhythm, you immediately commence with the chest compressions. But if there is an issue, like if it appears like, now what is a non-shockable and a shockable rhythm, I would just quickly tell before I move on, because as we said, if it is showing a non-shockable rhythm, so which is like, either you would get a flat line, or it would show some organized rhythm, but there would be no pulse. Now, if it is showing, so these are non-shockable rhythms, where that means that the heart is contracting, the rhythm of the heart is either just not present, or it is contracting normally, but the flow is still not happening within the body. That is why you're not getting any pulse. So these are or this would be called as pulseless electrical activity. However, the shockable rhythms are something that looks either so fine like this, like erratic pattern like this, or a zigzag pattern which is like VT or VF. So when either the heart is now fibrillating or in a tachycardic mode like this. So these are the shockable rhythms. If shock is advised, you would immediately um, get this patient to be shocked by putting the pads here and here, and ensuring that the person who's in charge of the defibrillator um, calls out properly that he's about to deliver shock, so clears everyone and delivers the shock. But as soon as the shock is delivered, you need to ensure that the chest compressions begin. So the only difference is at once you have at every 2 minutes when you are checking the pulse and the rhythm, you check whether it's a shockable and a non-shockable. And if it is non-shockable, you continue with chest compressions. And if it is shockable, the only idea is that that means that the heart is beating in an erratic manner. So by shocking it, at least you can get the heart beating in a normal manner. So and then you would do chest compression. So non-shockable, continue chest compressions immediately, and if shockable, then uh, shock the patient and continue chest compressions immediately. That's the only difference of shocking and not shocking. But say you've given the first 2 minutes were over, and then you say you delivered a shock. Now what you're going to do, you continue with IV access. You get IV access, ask this person to get IV access, load and prepare drugs, and adrenaline you would give, which is 1 milligram of basically in the dilution of 1 is to 10,000. So adrenaline you would keep, and you would administer and tell the person to administer it every 3 to 5 minutes. After 2 minutes, now let's look at the what the response is again. So any pulse, any rhythm check, and consider switching roles, and then think of any causes of what or causes when we are thinking. So think out loud that I am now thinking if there are any reversible causes to this cardiac arrest, which are called can be remembered as 4 H's and 4 T's. So H, hypoxemia, hypovolemia, metabolic cause such as hyperkalemia, and hypo, and sometimes hypothermia as well. So you need to think this. And T means if the thrombus, pulmonary or cardiac thrombus, tension pneumothorax, cardiac tamponade, or toxins. So these, as you are thinking through, you also communicate with the team. If you are not able to, then and in here, which is very important to understand, that a team leader and a good teamwork works on effective communication. So while you are thinking of causes, you also need to be communicating with your team. So in here now I tell about um, the, principles of good team dynamics. So people should have clear roles, and they should be, when you are communicating, it should be a closed loop communication. So if you are talking to the airway person, amongst all this chaos, what if you ask him, can you see the vocal cords, and then he should say, yes, I can see the vocal cords to you. Otherwise this communication loop is not closed. So this needs to be followed. There should be a mutual respect, which is this should be underlying, and clear messaging should be there. And so there should be clear messaging, and in mutual respect adds to the civility and cooperation in the team. You should be mindful of your own limitations and limitations of any person. So if the person at the airway says that I cannot intubate, so you need to respect that and acknowledge that. You should also so you should be also mindful of your own limitations. There should be, when there is all of these principles are being followed, it creates a platform for knowledge sharing, so people can um, uh, also do constructive intervention, which is add, if the team leader says I'm thinking of these causes, and then somebody can step in and say okay, this is also that can be thought. And the team leader needs to then make a summary and a plan, and also sort of summarize his thoughts, so that it becomes a shared mental model, because the team is working on his behalf. So creating a shared mental model, such as say announcing that it is a cardiac arrest, so it gets everybody into thinking the same thing. And once all of this is done, you need to debrief your team. Now, say if it was a shockable rhythm, and just to know that if you have given one shock, two shock, three shock, then you need to give amiodarone, which is 300 milligram in the first time. And if you have to give it subsequently, then after five shocks also, if the person is showing shockable rhythm, you can give 150 milligrams of amiodarone. So um, among all of this, while you are thinking of circulation, airway, breathing, think that can enduring the getting Lucas, getting pads which can be connected attached to the patient. So those sort of defibrillators are quite helpful, rather than using those pads that need to be applied jelly and applied to the patient. And because these, if just create a less noise and chaos at the center of the cardiac arrest. And I also think POCUS, which can help you in identifying reversible causes of cardiac arrest. POCUS means point of care ultrasound. So an ultrasound can tell you about say tension pneumothorax or cardiac tamponade, and the beating, the activity of the heart. Now you are running the code, you are running either getting you are ensuring good quality chest compressions are on, you are ensuring that the air the patient, there is good chest rise, or either the advanced airway has been placed, or and you are ensuring good team dynamics. So between all of this, you need to keep patient at the center, keep thinking of um, now and also as the time goes by, you need to think how beneficial um, is any further activity going to be. So but continue your best efforts, and this in some cases, if it is a case of hypothermic cardiac arrest and a person has been young or drowned, so in these cases prolonged cardiac CPR can be continued. But otherwise at 10 minutes, and consider after 10 minutes or 20 minutes, you should just think of the utility or the futility of your life support activity. So, as a team leader, you need to stand at the foot end of the patient, command your team, maintain good team dynamics, and know what is going inside the patient. Think of the flow and be in a flow state yourself. But keep patient at the center. And if you get ROSC, and ROSC means that the blood flow is now being has been achieved, you immediately then adopt an ABCD approach. Think of airway, get an advanced airway at this point if possible. Breathing, check that oxygen saturations are maintained in a good range of above 94 oxygen. And if consider ventilation, whatever needs to be. Circulation, think of circulation, so IV fluids, if or need of any vasopressors. Think checking pupils, checking documenting GCS. And E means everything else, and exposure, so think of that. But also think of getting a bit of history, getting family involved and updating them. Sometimes in some cases the family members may be watching, so always may keep the environment and the communication respectful. and so you could take a sample history, so signs and symptoms of the patient, any if once the ROSC is achieved, so and allergies, past medical history, current medications, last meal, and so these you could take as a quick history after the ROSC is achieved. However, getting an ECG can tell you whether there is something going wrong with the heart. A blood gas, an arterial or venous blood gas, can tell you a lot about potassium, the oxygenation status, the pH, and other bits. And so the three basic investigations that you could order is ECG, ABG, and chest X-ray, which could tell you if there is any pneumothorax and other bits. So with this, think of the plan and think of the intervention that the patient is going to need, and that is how you should run a code. I hope you enjoyed it. Thank you.